So welcome back, everybody, to another webinar organized from Princeton for everyone worldwide. And we're very happy to have Acharya with us from NYU and former Deputy Governor of the Reserve Bank of India. Viral will talk about the COVID lessons from India for emerging economies, including Africa and other emerging economies. And we're very glad to have him with us. And before we give the floor to Viral, I will make some few opening remarks on this topic as well. So when you look at the current situation in India, the important COVID lessons from India. So first we have the Delta variant of the COVID virus, which is more contagious, and it also hits the young people. So typically we were hoping that, emerging economies will be less hit because a larger part of the population is young and hence less exposed to the COVID virus. But the Delta variant is actually also hitting a lot of the younger people as well. And the big question of our times, and actually everybody woke up to it already, is that how will actually this affect other emerging economies and developing economies, in particular also in Africa? And so what can we learn from the experience in India for the other economies? In particular, if you look in Africa, there's only 1% of the 1.3 billion Africans are vaccinated. And a lot of emphasis is actually pushed on how to finance vaccination and how to produce vaccines for Africa and other emerging economies. But less emphasis is actually put on the distribution and the delivery of vaccines, and also other health measures one could take and prepare for at the moment in order to be ready if other continents and other emerging economies are faced with a similar crisis as India did. And so I would like to focus a few words on that and then focus on this. So what's special about India, essentially there are two models you can go for. One is that you have the vaccine production and you have the vaccine distribution aspects to it. And India is special because India is a big producer of vaccines, probably the largest in the world. And then you can actually spend the resources to produce vaccine in Africa, for example, on your own, or you can actually focus more on the distribution. And there are a lot of measures which are necessary if you want to produce it, to financing measures, and also remove some cross-border export restrictions in order to get the raw material for the production. But this might take too long and we might not have the time for that. An alternative approach is that you have the production mostly in the advanced economies, focus on the new mRNAs vaccines and produce them there and then distribute it freely to the emerging economies. And the emerging economies focus very much on how to distribute the vaccines and make other healthcare measures, and that's typically more important. Of course, the obstacles in general, in this regard, but that's essentially one approach. And I would like to focus on the distributional aspects, where the advanced economies in India produce essentially vaccine, and to some extent somebody finances it, but not the emerging economies themselves. And the distribution is then guaranteed. As long as the emerging economies guarantees they are able to distribute the vaccines, actually that's the condition they have to satisfy in order to get the vaccines on their own. And then the question is, how should you distribute it? And if you look at the experience of the advanced economies, the focus was to first roll out the vaccine to the most vulnerable ones. And that's, typically strategy. In particular, the elderly people were hit much harder and the younger people were not so hit. So the most vulnerable got the vaccines first, or put it in economic language, the ones which are exposed to the externality from others. An alternative approach is that you actually give the vaccine first to the multi-spreaders, or put it differently, to the guys or the people who cause the externality, not the ones who are exposed to the externality, but who cause the externality. So the advantage of this is, of course, that if you look at this picture here, there's one spreader is spread to 3 people, and then they spread it out to 9 or 10 people even further. If I can stop by vaccinating the first guy, this multi-spreader, then I can save all 10 people. So it's much more effective if I can actually vaccinate the multi-spreaders. But that has a totally different strategy compared to trying to vaccinate the 10 receivers at the end. But I have to identify the multi-spreaders, and that's much harder to do compared to identifying just who is an elderly person and who is more exposed to that. So I need data, and I think Viral will talk a lot about how important it is to have timely data available in order to have the right measures. But it would be a very radical shift, essentially, in terms of distribution, away from focusing on the vulnerable people by focusing on the multiple multipliers and getting essentially the R down below 1 by focusing on these people rather than focusing on the vulnerables who receive or on the receiving end of the virus. Now, another approach essentially is another handicap is that people might be hesitating getting vaccination. And one approach would be to use mobile phone implementation to really explore the mobile phones much more dramatically. And there's a proposal, I talked a lot with Jean-Pierre Landau about this, and there's a proposal out from the African Development Bank saying we should actually incentivize people to get vaccinated and give a financial incentive to pay. But there's also a literature in development economics focusing on social signaling, where it's essentially you signal to the public that you have gotten a vaccine, and then you get some extra benefit from the society because you signal that you're a good person, you care about the externalities you cause on others. And this is typically done by recent work by Anne Carring and others with wristbands. You get the wristband, you get the vaccination, you get the wristband, you signal to the others because you got a particular color to do that. But you can also do this with mobile phones. And here the idea is that if you get vaccinated, from then onwards, your mobile phone provider, whenever you make a payment, the payment comes to the other mobile phone receiver, comes with a different color or with a different ringtone. So you could actually also do this on the mobile phone dimension. It wouldn't cost much, unlike this pay, which might cost significant amounts of money. The social signaling might be equally effective in order to overcome the hesitation to get vaccinated. Of course, mobile phones, I think, is one of the key strategies also to make the tracing more effective. If you want to focus on the multipliers or the guys who really multi-spreaders. And we have learned a lot from Taiwan and Korea. They have really made this effectively. But of course, we have to take the privacy considerations into account as well. Now, another aspect where we can learn a lot from the Indian experience, and that goes back to some work and what the Ramanan Lakshmararyan did and has actually initiated in India. He was on our program, our webinar series before last year. And it's Oxygen for India, where he raised a lot of money in order to make the oxygen supply available in India. So one of the big challenges is once people get COVID, how can you treat them and make sure that they don't die and provide oxygen? And there's certain challenges with respect to oxygen, in particular for rural areas. If you look at the oxygen production, it's mostly in the big cities, because most of the production is actually for industrial purposes. Only 15% is for medical supply, and you can relocate and can make sure that there's enough need. But of course, the demand went up 10 times for medical reasons, so there was not enough supply in India. And you can prepare already in other emerging economies for this supply at the moment to increase the supply. And it's fairly cheap. It's, one cylinder is about 70 cents in US dollar, not even $1. So that's one way to do that. And then you have to think about how to redeploy it. So one is, do you want to have locally, you might not know where the COVID crisis is breaking out. Do you want to have some centralized oxygen redeployment units, which you can redeploy depending where you need it? Do you have some strategic reserves for that? At what level do you want to have the strategic reserves? Do you want to have it only in the big cities, or do you want to have it, a much more regionally distributed and so forth? That is all open issues. One problem with oxygen is that you cannot move it very, very fast. So you can, I think, only move it by 30 miles per hour. So these are all important steps one can take already now in order to be prepared if the Delta virus variant is coming. And of all you need, all of this, you need data. So having data, where is the virus most prevalent at a timely fashion, and that's very, very important to have. Of course, the other economic problems, there might be people hoarding oxygen or institutions hoarding oxygen, of saving it for their own people. It was less of an issue, I supposedly, in India but it was more for drugs. That's a bigger issue, that people are hoarding them just in case if they fall sick. There might be a shortage of this as well. So there are a lot of lessons. All of them point to them. If you want to have effective policy, you need good data. You have to capture this in your data, but there are many steps one can take. Some of them are fairly cheap. It just requires some good governance and some implementation, and hopefully, we can, contribute to this as well. Now, Viral also proposed certain poll questions, and you answered these poll questions. So the first question was, what do you think was the percentage of the Indian population that have died during the Spanish flu in 1918, 1920, so more than 100 years ago? And the majority actually said 5%, and Viral will tell us later on what the truth is. So almost 48%, almost half, said it's 5%, and otherwise it was equally distributed among the other answers. The second question was, what's the estimate, the undercount of COVID cases relative to totally infected based on the antibody tests in India in December 2020? And the majority answered 46% that 10 times it's undercounted. 35% thought 5 times it's undercounted. And then there were 25 and 50 times undercounted was 10%, 10%. Okay, so majority was 10 times undercounted, almost 50% said this. The third question is, what's your guess of the ratio of total to reported COVID death? So that's now not about cases, but COVID death in India during April and May 2021. And the majority here said, or 60%, so a big majority said 3 to 10 times was the undercount. And then we had about 20% 1 to 3 times, and we had 13% 10 to 25 times, and 8% 25 to 50 times. Again, the majority, big majority, 60% said 3 to 10 times. And finally, put yourself in the shoes of a prime minister or some politician in some African country after facing the third wave. What would be the first policy response? What should be the first? Flatten the curve in the case with social distances, arrange the vaccines and the vaccination drivers, or cut the interest rate, or provide fiscal stimulus. And one could say you should do everything, but if you really have to do most of it, the big majority, 56%, arrange the vaccines. And that's what really everybody is focusing on, rather than flattening the curve, which was 38%, and cut the interest rate, only 2% said. And I think Viral would probably agree, even though he was a central banker just a few years ago at the Reserve Bank of India, and provide fiscal stimulus 4%. So the majority were really focusing on vaccines, and then followed by the flattening the curve with social distancing. So with this is a quick summary, a quick introduction. I leave it up to Viral. I give the floor to Viral. He will give us a bigger picture of what went on in India, and how the data and the undercount really played out during this period, a recent period we experienced.
Great. Thank you so much, Markus, for inviting me. Let me share the screen. Okay, so at the very outset, let me just start off with the disclaimer that I'm by no means an expert on health, by no means an expert on epidemiology either. Maybe I've just been a student of COVID over the last 18 months. And one view of Academy is that it's a place to learn. Of course, another view is that it's a place for scholars, etc., to enforce certain standards in the profession. But I think for me today, it's very much the place to learn. And I'm just sharing and discussing, conversing with you about some things I've gathered over the last 18 months from India. And normally I wouldn't start out by saying where I got my PhD, etc. But I think in case of COVID, I just have to give some sort of an experience. So New York, as you know, was very badly hit in the first wave. And I think by the time you knew 5 to 10 cases around you, right in April itself, you got the sense that this was around you, sort of in the air, literally. We had some long COVID cases around us, and unfortunately, then a fatality within 1 degree of separation during the second wave. And then, of course, we had the Indian wave. The Indian first wave relatively didn't come close to me in any way. But during the second wave, my entire family was infected. And in fact, my father was quite critical for 7 weeks. I was there during that time, battling with the healthcare system at very close quarters. And unfortunately, there were a very large number of fatalities around within 1 to 2 degrees of separation that also help you understand what exactly was going on at that time. Perhaps these experiences have made it hard for me to think about COVID other than through, first and foremost, through the health lens. Maybe the March 2020 could be considered as a nice exogenous shock for some natural experiment studies for finance, economics, etc. But my sense is that anything else we do with COVID, we may have to actually think a little bit hard about the health underpinnings, so we have the right initial conditions in our research. And as Markus explained, I think people are trying to learn from India's experience. I think it was quite shocking to many people, even to just read about it, even if media does tend to focus on the most salient facts rather than the average facts. But several ministers and health officials in Africa have expressed that it really scares them if an Indian-style scenario was to reach there. What would they do? And as we speak, the third wave is actually getting quite steep in Africa. And just to put things in perspective, on the left, you have India's wave. The reported cases at its first wave, at its peak, were about 100,000 daily cases. And during April and May, which most would agree was the peak of the second wave, you had the highest daily registered cases in, I think, globally in any country, upwards of very close to 400,000. And one thing that is interesting about both India and Africa is that, of course, levels of vaccinations are low. In India, it's not because the absolute number of vaccinations is low. Absolute numbers are large, but India has a very large population. In case of Africa, even the basic absolute numbers of vaccinations are actually very, very low. So I'm just going to draw some lessons. I have been doing some data work, as Markus mentioned, to understand the likely death undercounts in India and how to make sense of the dynamics of the data that are coming out, what we can learn from them, what sort of patterns may arise. And I'm going to focus mostly on the healthcare capacity issues, how limited healthcare capacity can transform what may look a relatively benign disease for a country in terms of overall fatalities into something that is far more perilous, especially in the surge or the peak periods. But before I do that, I thought it would be interesting to go back and see what we knew from the previous global pandemic, the Spanish flu of 1918-20, and perhaps what we knew in March 2020 from the epidemiologists, in particular through this Imperial College report that had come out. And the Spanish flu of 1918, on the back of World War I, I'm sure most of you are aware, had a much higher infection rate than the current pandemic, and also had a much higher fatality rate. I think it's a particularly interesting historical episode to look at because that time vaccines were not on the table. And so, non-pharmaceutical interventions such as social distancing, quarantine, etc., were only the way out. And perhaps what is less well known is that India was, in fact, one of the worst affected countries during the Spanish flu. The World War I troops that returned to India, they brought the infection. Unfortunately, there was a famine that made the health situation particularly worse. And I think, as most of you guessed or answered correctly, about 5% of the population in India is estimated to have died during the second wave of the Spanish flu. The estimates range from about 12 to 18 million. And it was so large. And one aspect of the Spanish flu that was different from the variants we have seen so far, perhaps with the exception of the Delta variant, in some extent, is that the Spanish flu affected the young the most. So those in the age group of 20 to 40 died the most. And unsurprisingly, there was a reduction of births in India in 1919 by a phenomenal 30% as a result of that. The healthcare system then was also unable to meet the surge. And as India was a British colony that time under their administration, this actually led to an increase in the emotion against the colonial rule. So on the left, you have the fatalities per 1,000 persons globally, but I'll focus on the right-hand picture, which shows the monthly death rates per 1,000 people in India. This is from some excellent work done by Chinmay Tumbe, who is a historian at Ahmedabad, one of the management institutes. And you can see that the excess deaths, if you were to use compared to the similar months in 1918 end, were just a factor off. And you can see that the factors here would probably be on the order of 10 to 15 in terms of the excess deaths during this time. And evidence on the use of non-pharmaceutical interventions, not from India, but more broadly, seem to suggest that, at least from the standpoint of containing the cases curve, there was some evidence that these were successful, especially at the peak. So this is one of the papers published in the National Academy of Sciences in June 2007, which showed that cities in which multiple interventions were implemented at an early stage, at the peak of the pandemic, the death rates there were lower by 50% than those that did not implement such reforms. It wasn't possible for this study to find any support for a specific intervention, so they seem to work collectively as a package. And also the average cumulative mortalities were not that statistically different between intervened and non-intervened districts, but the peak performances were very different in these cities. So the epidemiologists had, my sense is, through whatever I've tracked over these 18 months, figured out that this may have to be one of the first rounds of defense. And this was reflected quite heavily in the Imperial College report that had come out in March 2020. There is disagreements on, whether it was sending the right messages and so on, but I'm just going to show you a few pictures that they had put out, which I thought were perhaps quite prescient about the kinds of situations we might have to deal with. And this report had alerted that simple suppression measures such as isolation, quarantine, more complex or draconian measures such as isolation, quarantine will be necessary to contain spread and buy time. And the focus in this report was primarily on not running out of hospital beds. They were first and foremost concerned about that bottleneck. It also recognized that more standard and simpler mitigation measures that allow the spread, but sort of just contain it to decent levels, hoping that herd immunity will be reached, will cause overcapacity problems. Okay, this was one of their inferences based on their simulations, and that likely measures undertaken to deal with the health front will likely cause economic disruptions on a global scale, only some of which are already being witnessed. The report, I think, came out around middle of March 20. And they had these interesting sort of simulations where they showed us, this is for UK, in their appendix, they showed it for the US as well, that if you looked at the critical care beds occupied per 100,000 of population, it's actually a very low line in the red in the first top graph. And if you simulated the number of cases based on what they thought would be the SIR model parameters for COVID, essentially, there was going to be a surge very, very soon in the UK as per that estimate in April 20 itself. And then the green line, the orange line, etc., correspond to undertaking a variety of non-pharmaceutical interventions to suppress the pandemic. You can interpret the orange line as sort of the weaker measures and the green line as the stronger suppression measures that involve school and university closure, greater social distancing. And essentially, if these were implemented from April to September, they showed that you would stay below the hospital bed capacity. But of course, the R0 ratio of the infected to the vulnerable would not yet be that attractive. And so the moment you relax the measures, the curves would begin to rise again through infections and relaxation of suppression measures, contact intensity, etc. And then you might have to go through a series of such sawtooth waves of suppression measures, bringing the infections down, allowing them to spread again, and then bringing the measures back again. Markus, did you want to?
I just was, do you want to emphasize it's very important that there are some official measures, or is it enough that people are scared and do social distancing on their own? I mean, all of these SRR models don't really take behavioral responses into account and the expectations of the people. And perhaps what the lockdown did in India in March 2020 was essentially just sending a signal how serious the problem is. And it was not the lockdown itself, it's just scaring the people and then changing their behavior by scaring them rather than enforcing a strict lockdown. Would you say there's a big difference between the first wave and the second wave in India? The first time people were much more scared and were more careful. And the second time around, not the wrong signals were sent, and that's why it spread so more dramatically.
Yes, I think we'll come to this in some greater detail. But just jumping ahead, I think at the time of the first wave, India actually imposed a national lockdown, which was actually imposed with just a 4 hours notice. So actually, its immediate rollout was quite chaotic. But in some sense, people actually didn't have a chance to respond because a high-level national decision was taken to impose a lockdown all over the country. I think the second wave response, perhaps the behavioral aspects become more crucial in understanding how individuals would respond. My colleague Thomas Philippon has a SIR model in which he looks at the individual biases in adopting the distancing measures, etc., and the natural externality sort of biases come in. My own experience in New York and both in India was that in the early phase of the wave, because perhaps we form our expectations adaptively based on the past data, given the scale of uncertainty we are facing, there tends to be an undershooting in the containment measures adopted by individuals themselves. It could be both because of lack of understanding the curves of the exponent when this curve grows very large, maybe not knowing when the medical capacity will run out and hit you hard. But perhaps there's also lack of internalizing the spillovers, the fact that by getting infected as a young person, maybe even if you think you'll be okay, you are actually exposing a lot of vulnerable around you. However, I could see that at the peak, once you start getting close to the peak, or once you start hearing that hospital beds are not available, I think I do see a very big shift, anecdotally, at least in the individual responses. But perhaps the bigger point might be that if the data are simply not great, and if the reported cases, reported deaths, information on healthcare capacity that is available is not that reliable, I mentioned later in the talk that it looks like, you are driving with a lot of blind spots and you are bound to have accidents. And I think that is one lesson from India I would particularly like to emphasize, that there's just tremendous value to getting the right stats and getting a handle on, if the stats are not right, what's the extent of bias, underreporting bias that's in the statistics. Because open discussion and dissemination of that can help individuals at least get to the right responses, once they are in a stage where they are willing to internalize the spillovers. So in essence, my sense is we did have information at the beginning of the curve that flattening the curve is going to be quite important. I think many economists and finance researchers, including in the participants list today, who had alerted everyone that perhaps we need to handle the health issue first. We can worry a bit later about what sort of backstops the entire system needs on the financial side. India's second wave in particular is a good example of this Imperial College report sort of surge capacity being breached, and what sort of implications might that have on the statistics that you get on the curve. So with my former IIT colleague, Dr. Tushar Gore, we started looking at some data. He's the one who really specializes in COVID statistics. He has been writing quite regularly in India, analyzing the limited pieces of data that are coming out. But we did some work to do something more structurally on this issue of healthcare capacity. How does it work in practice? And essentially, it looks something like the following. And this was just a sketch of how the patient overflow situation arises on a day-to-day basis. So suppose there are 6 days that a patient needs to spend in order to be treated with COVID. Just for illustration, it's typically much larger. And let's say that we are looking at 6 daily cohorts of patients that have entered into the COVID hospital. And the blue horizontal line at the top is the capacity of the medical system in terms of oxygen and ICU beds in order to handle these patients. Then, of course, as time goes by, the existing COVID patients are exiting from the system. Either they recover or they might face a fatality. And newer ones are entering the system each day. Now, once you hit the capacity, of course, the excess patients who need to be hospitalized, which are in the red bars at the top, are now going to fend for themselves. And this is where we think that the peak problem of deaths in India arose from, which is that a large number of people, even relatively young, as Markus mentioned, the Delta variant seems to be infecting them a lot more, and at least get some care is needed for them to get to some basic oxygen support at times. A number of them actually died because simply there weren't beds available. And what you would ideally like is that this horizontal line, which is the healthcare capacity, should really, like a rubber band at that point, become a triangle, extend itself to actually absorb these red cases into the healthcare capacity. Now, of course, the question is, have you built such resilience into your medical system? Do you have an estimate of how many of such cases are likely to arise and with what speed, etc. So what we do is we simply put this sort of a structure into the data. Okay, so in many SIR models, when they think about congestion or overflow problems, many of them, not all, they directly model the infection rate as being an exponential function of the number of cases that are likely to arise, for example. It means I'm myself guilty of doing this in some work I'm doing. But of course, what you would ideally like to do is something similar to what the Imperial College report was doing, which is that you actually have the number of beds capacity as a parameter in the model. Because it turns out that that capacity interacts highly non-linearly with other disease parameters, such as the infection rate, the hospitalization rate that is required in order to know when you are in the strike zone, when are you likely to actually hit the constraint. And it's not possible to just model that in a reduced form manner right away. So it turns out, though, that this requires a lot of data. And you need to make several assumptions to calibrate such a model meaningfully. So firstly, you need percentage of daily new cases that need hospitalization. And unlike in the Imperial College report, where it was the same variant that was producing waves after the other, in reality, we are actually facing new variants each time. So you may or may not have a good handle on the current variant's property about the number of cases that need hospitalization. The first wave in India needed 6% of the active cases needed oxygen or ICU assistance. The UK evidence on the Delta variant so far is that it is twice transmissible and perhaps it's needing twice as many hospitalizations as a result. When you are in the peak of a surge, of course, you have many people not getting the kind of medical attention they need. Cases become more complicated. And so we are going to assume a baseline of 15%, but do sensitivity around 12 and 18% hospitalizations of daily cases. Now, the issue, though, is that when you're trying to estimate such a model structurally, you need to know how many cases are there that day. Now, of course, the hospital capacity getting breached or not depends on the actual number of hospitalizations. And what you have in data are just the tested and the reported cases based on whatever limited testing is taking place. So if you just went from reported cases and applied the hospitalization rates to know when your medical system is going to hit capacity, you would be painfully late in responding at any point of time. And I think this is one of the fundamental differences between simulating an SIR model versus working with real-time data, which is that you don't know what the total infections are at a given point of time. Now, what is the way out? My co-author and I think that what we need are seroprevalence surveys. We need to know on a real-time basis through serum collection and then its assessment for antibodies as to how many people are infected in a population at any given point of time. Two advantages, of course, if you're able to estimate, but more importantly, because you can't really do it every single day, what you need to back out are the multiples, which is what are the reported cases relative to the total cases that you are finding in your seroprevalence survey. So in India, for example, at the end of the first wave, from August to September, 70 districts underwent through a national sero survey. It was about 29,000 individuals in 15,000 households in the age group of 10 plus. This was actually the second survey. The first survey, unfortunately, the results are not visible anywhere. The second survey, the results are in a Lancet study. And the Lancet study also refers to a third survey that was done right after the second survey, and which actually shows that many of these multiples of the total infections to reported infections actually stayed constant over a period of time. And that's also another valuable statistic to have, because you know that these multiples, so in case of India, this was 26 times at a national level. Of course, there's district level variation in this. Now, we are going to apply the same 26 on the second wave, but of course, we don't know whether this is the right number to use. We are going to make an assumption that it was at least 26, because likely in the second wave, probably the underreporting was greater. But we are not 100% sure, because the test positivity rate also went up during the second wave, which suggests that maybe testing was actually catching up in part, also like a rubber band, as I was describing. So, but I think this is one important message, which is that the seroprevalence surveys are very important to do any real-time prediction work on the needs of the medical system.
And was there a lot of cross-sectional heterogeneity across 70 districts in a sense, or you will go to that, I guess?
Yeah, I would say, I've used the 2011 census of India to classify these districts into the rural versus urban population. And it ranges all the way from 20 to 90% in some cases. There were also local seroprevalence surveys that were conducted by individual city level municipalities in New Delhi, in Mumbai at different points of time. Their reporting is just not standardized, but in principle, one can also aggregate those data to do some of the forecasting work that we have. Then you need to know number of days in hospital due to the disease. We're going to estimate that at 14 days based on some data that we've gathered. We think during the second wave, it was much greater because comorbidities and complications were far greater, especially secondary infections. The longer you have to spend time in a hospital, especially in hospitals where not necessarily sterile conditions are being maintained, secondary bacterial and fungus infections can actually force the patients to be there for much, much longer. And then you need to know the total capacity of oxygen and ICU beds. And here I want to emphasize a very important point of granularity, which is that, of course, there is national data on oxygen plus ICU beds that is very easily available. But that's not of much use in knowing when the healthcare capacity is going to find, because we can't share oxygen and ICU beds even across districts. So the analysis of the model has to be at a granular level. You actually need to have this information at the level of individual districts, or whatever you think is the right constellation of villages, townships, within which some healthcare sharing might be possible because distances are commutable, for example. And there can be huge errors if you try to apply this in an aggregation that is wrong. Because if you have a district with low healthcare capacity, another with high capacity, you might just add up the two and think you can actually go through the wave very, very well. But it will completely mask the fact that one district is going to hit the healthcare capacity, and the fact that you have surplus elsewhere doesn't really help you hedge the risk of the first one. And now, beyond this, you need to, of course, know the normal fatalities that would be taking place even amongst those who do get the care. And, you can estimate these again using infection fatality rates. So you need the total infection. So you again can't go by reported cases. So you need seroprevalence surveys to give you the right multiples, and then you can get to the right infection fatality rates. For India, it was rightly estimated that India's infection fatality rate was low during the first wave. It was 0.1%. And because the health was not too congested during that time, this can be reasonably considered as sort of non-congestion or non-patient overflow infection fatality rate for India. Again, the infection fatality rate varies regionally as well, and seroprevalence surveys can also actually enable you calibration of the model at a granular level in this manner. Now, to get back to Markus's point that data are so important, when you think about applying such a model in reality to an actual district, you realize that some of the inputs you need are disease or wave or variant specific, such as the infection fatality rate, the hospitalization rate, and the number of days in hospital. So we really ideally need to know where we are. Maybe one country's experience helps guide other countries if the variants are spreading as they have with Alpha and the Delta variants. You also require a lot of location-specific information. So you need regional dashboards, at least that was the term that was being used a lot in India, on healthcare capacity. So your oxygen and ICU beds, your oxygen and ventilator supply, medical staff, available nurses, etc. And to do real-time work, you need to be able to go from reported cases to actual cases. And for that, you need the seroprevalence surveys. Okay, so the data demands are high. And I want to stress these, that the sero surveys have not got as much attention as one might have thought. In fact, I think in the poll, I think the estimate was about 10x for India during the September to December 20 as the most voted answer. In case of India, the estimate was 26. It was 26 times from the reported cases to the total infections. It's not a widely known statistic at all, that India's first wave itself was actually quite severe. And looked at it from another side, that India was nowhere close to herd immunity either, because that was just not enough in terms of the percentage of the population.
So Viral,
I think there's a question, I think. Yeah.
Yes, by Robert Owen. He would like to know. So if you look at a lot of these reduced from COVID models, they really missed some of these nonlinearities, and you captured by the threshold nonlinearity. Do you think that's the most important nonlinearity in a sense, by having this threshold, or just do the other nonlinearities we have to consider as well?
I don't know the answer to that, to be frank. I think that you ideally want to keep the realized infection fatality rate to the same level as the disease's inherent infection fatality rate. Mm-hmm. I think you want to avoid the deaths that can be avoided, at least narrowly thinking about it from a health front. And my sense is that once the realized infection fatality rate exceeds the disease's inherent infection fatality rate, you have no choice but to do a lockdown. There is just no other way out. You have to just shut down the spread, because, both from a humanitarian as well as a political front, it's just an entirely unpleasant experience. And so I would tend to think this is certainly one of the most important non-linearities in my view, the hospital capacity. And you can actually see also in the human behavior, which is most people are okay with their lives until they get a newspaper article or a text message that ICU beds are running out in the hospital in their neighborhood. Once they know that they are not going to have access to medical health care, the behavior of the individuals changes very, very sharply. So there may be other spillovers that are not actually being considered in the simple sort of patient flow model that we have out here.
But this behavioral response essentially is a correcting force. It helps to stay below the limit, I guess.
Absolutely, absolutely. I think the problem, though, many times is that the virus load has become so high if you react too late. So you ideally need to respond before you've actually hit your healthcare capacity. You ideally never want to see an article that's saying you are running out of beds in the first place, because if the behavioral response takes place when you are already hit in that situation, and this happens in a correlated manner usually across a large number of districts. So by the time the lockdown suppresses the spread of the virus, it may be another 4 to 6 weeks. And you could see a lot of.
So you might argue that I don't want this capacity to expand, because then the newspaper article is coming out later. So it might be actually, I would like to spread some news that actually we're running out of healthcare capacity or ICU capacity. This way people change their behavior, and this way, I step on the brakes earlier, rather than saying, okay, I double my ICU units, and then people get not scared, and then the situation is getting out of hand much more quickly. I don't know what's the trade-off here. Have you thought about this?
Yeah. I'm not sure if these are necessarily exclusive. I think my sense is there are both logistical and financial constraints on expanding the healthcare capacity beyond a point. And I think therefore you do want to lean on data dissemination as well as a tool, because I think you want people to understand the spillovers that are likely to face themselves and others in their families and around them. Yes.
So in a sense, you would like to forecast running out of healthcare units rather than getting very late the data. So the speed is of essence, I guess.
Yes. And I think our hope in trying to estimate such a model with the past data is that one can actually run these kinds of simulations at a district level. And, you can think of it as a stress test if you want, which is that, if I observe what the properties of the variant are, and I know my district's capacity, in how many days am I likely to probably get to the capacity? How much time do we have? And then, like the Imperial College report, you could do some simulations then to understand how much I need to reduce the spread of the virus to keep it below. But I want to stress that it has to be done at a district level based on the medical care capacity of that district.
So I should let you go on, otherwise we won't make it in time.
Sure. So let me just show you what comes out. So out of the 70 districts, we picked 6 districts. Partly we picked these 6 districts because there is also data coming out in India on the actual death registrations. It's also not something that is very easily publicly available, but some journalists have been applying to the Right to Information Act in order to get the data. And for 2 of the states, especially the state of Madhya Pradesh, these data have become available, and they are finding that death undercounts, especially during April to May 2021 in the second wave, in terms of excess deaths. So if you looked at April to May in 2018 or 2019 and compared that to 2021, the multiples are on the order of 30 to 40. Okay, and we wanted to get a sense of what does that mean in the context of a medical care capacity congestion model of the type I was showing you. So I won't have too much time to go through the basic summary stats, but those are the 6 districts we focused on. 3 of them are in the state of Madhya Pradesh, where these counts of 30 to 40 have been documented. 2 are in the state of Maharashtra, where Mumbai is. And 1 is Bangalore urban area, because there the city municipality has an excellent dashboard that was giving us easily available data on the medical care capacity. You can see that on the bottom table that, as Markus was asking, that the urban population ranges from 20% to 91% across these districts. We tried to pick some cross-section of that. In the Zero survey, you get a sense of the actual infection undercount. So in the top panel, that's the second from the right column. And you can see that in some cases, the total infections detected through the prevalence of antibodies was more than 30 times, whereas in Nashik and Bangalore, it was on the order of 18. And you can also see that the realized infection fatality rates at the end of the first curve, first wave, which is the last rightmost column in the top panel, they are relatively low. They are, the average nationally is 0.1%. And many of these districts had overall fatality rates on the infections that were actually smaller than the advanced economies. Now, one downside of this infection fatality rates being low was that no one could really explain with great conviction why they were low. And there was a sense that somehow the virus isn't affecting Indians for some reason. And I think that created a sense of complacency. There was also a sense that we might have reached herd immunity, and these infection multiples of 30 show that we hadn't reached herd immunity. These multiples are not as large as one might have liked. In certain slums of Mumbai, these multiples on infection undercounts were on the order of 60 to 70. So those specific districts and regions or zones in the city might have reached herd immunity, but this was clearly not a statement that was true for India as a whole. Now, what I want to show you in the bottom panel is that healthcare capacity in India tends to be low in general, certainly by global standards or certainly by advanced economy standards, and perhaps even compared to some emerging markets. The oxygen plus ICU beds per 10,000 people is sometimes as low as 2 or less than that in some cases. And on the 2 rightmost columns give the output of our model in terms of the max undercount that is observed in the deaths at the peak. They range from 17 to 95. Which shows that you can actually observe the multiples of 30 to 40 that are being reported in the peak of April to May, because some people just find the reports very incredible, which is how could you have an underreporting of deaths by 30 to 40? And our model shows that if you assume that those who can't get access to healthcare essentially succumb with very high likelihood, at the peak of the wave, everyone above the healthcare capacity is an overflow death, and you can end up with such counts. Of course, when you average over the entire pandemic, the cumulative undercounts are unlikely to be on the order of 30 to 40. They are in the range of 3 to 9, as is being observed.
So if I have this variation across the regions, how, as a policymaker, so how should I react to that? Should I just focus on the region, all the resources which has the biggest overcount or undercount, and say, okay, they have the least ICU units, so I have to help out most there, or should I spread it across? Does it give me immediately some policy reaction, the information?
Yes, so I think, so two things, Markus, that are important here, which is that the ratio max undercount is a ratio of deaths to the reported deaths.
Yes.
And what we observe in data is that that's also behaving and incorporating the pattern of reported deaths. So I think you don't want to go necessarily by this ratio, because that is not necessarily a measure of the actual deaths taking place, because it's deaths related to reported deaths. Mm-hmm. And our assessment is that in many cases, it's the reporting which has been woefully inadequate in terms of the reported COVID deaths. So what you do want to look at is the actual overflow and the breach of the medical capacity. And clearly you do want to allocate resources based on that statistic. I think the cumulative undercount is less influenced, and in fact, it is far less influenced by these reporting biases, which may be becoming stronger during the wave, because maybe the local administration or the state administration or the national administration doesn't want it to be seen that a lot of deaths are actually taking place. Mm-hmm. So as I just mentioned, what you see from this application of this model is that you can get daily death undercounts which are on the order of 25 and higher. Okay, so I'm just showing you for 3 of the 6 districts we analyzed: Gwalior, Indore, and Nashik. The blue line is the daily cases on the left-hand y-axis, and the red line is the our assessment of the death undercount multiple on the right-hand y-axis, and the orange shaded bars are the sensitivity analysis for 12% to 18% hospitalization rate around the baseline case of 15%. And you can see here that indeed, for a short period of time during the surge of the wave, death undercounts of 25 to 40 are indeed possible. But you can see in case of Indore, even before the peak of the surge, there is actually a huge undercount surge. And that's happening because the reported deaths in that week are actually practically 0. And so it's causing the ratio to spike. And this goes back to Markus's point on what you want to focus on. Now, there are two points which are important here. One is that while the dynamics are such that you can get this very large underreporting counts, of course, they should not be extrapolated to the pandemic as a whole. So some people immediately, once they see the 30 to 40 multiple in April to May, they want to say, oh, the total deaths in India has actually been 30 to 40 times the entire pandemic reported deaths. And that's simply not going to work out, because the overflow problem non-linearly hits during the surge of the wave. Second, there is an interesting statistic one can calculate, which we call as the calculated infection fatality rate. We don't want to call it the realized infection fatality rate, because for that, we would need to know the realized deaths with precision. And that data is coming from these excess death registrations that I was mentioning. But essentially, the disease or the wave has its own property of an infection fatality rate. Okay, so if you didn't have healthcare capacity problems, that's the death rate that you should observe in the data. Once you hit the medical capacity constraints, now you get a location-specific statistic, which is going to be the calculated IFR, and that can now exceed the disease's own property. Okay, what this also means is that when you observe the infection fatality rates in different regions, one should not extrapolate from that as a property of the disease, because this may actually have a component which is attributable to the healthcare capacity of that region. And we calculate this. So the black line here for the 3 districts is the death undercount on a cumulative basis. And the maroon line is the calculated IFR. And so 0.1% is the IFR until the non-linearity hits the healthcare system capacity. And then you get a component of the IFR, which is now due to the medical constraint out there. Now, what's interesting is that this can become twice or thrice as high as the disease's own inherent property. And I think this is what you want to control. I think you want to keep this under bay. I think I'll skip this in interest of time. Let me come to what are some of the implications of the overflow and the death undercount. So one question is, why are the deaths undercounted? A standard reason that is mentioned is that it's hard to attribute deaths to COVID because there are comorbidities that are at play, and patients can test negative but then have secondary infections. How can you be sure that this has been caused by COVID? Now, of course, medical profession recognizes this, and the WHO has given guidance to the governments on what decisions should be made based on whether the patients were symptomatic of COVID immediately preceding the fatality or not. I'm a bit concerned from what I've observed anecdotally is that comorbidities have offered a way to not actually recognize deaths as COVID deaths, because then they can be sort of buried under and not be seen as a failure of the medical system or the medical system capacity. A second possibility is that data on COVID deaths are possibly highly politicized. There are short-term political rewards to understating COVID deaths. It may alter perceptions of the leaders in place. Maybe it will lead to lockdowns, and leaders may be myopically focused on ensuring that let's hope the curve subsides and I can continue showing high quarterly economic performances. And sometimes there are relative performance rewards. One state, if it does better than other, there may be some political advantages from that. So I think at some level we need to factor this into account, that reported deaths while understanding the pandemic must be taken with a grain of salt. Second, I want to now come to the economic impacts because that will have some implications for the policy lessons. There is, of course, an impact on the rich and the formal economy. In some sense, COVID is tragically a great equalizer, especially when there is overflow. So at the time of the peak of the wave in India, in Mumbai, for example, even the richest families could not actually get an ICU bed if they wanted. There simply weren't physical beds available anywhere. And once that happens, of course, you're going to see deaths also in age groups that can be avoided. And this is the time when the human behavior becomes very, very sharp in response to the pandemic, as Markus was stressing. They withdraw very sharply from discretionary expenditures as they essentially go in a shutdown mode. And therefore, there's some evidence that essentially even the rich have been impacted quite a bit in India during the first wave. The evidence on second wave is not yet coming out. This is work by my colleague Arpit Gupta recently as an NBR working paper. The other thing that's interesting is that there could be scarring effects even through the rich. So there's a sense that the rich can rebound because they have buffers, their jobs come back more quickly. But one discussion that I'm hearing a lot is that those who can afford are wanting to emigrate out of the country or at least create foreign bases because they don't want to be stuck with a healthcare system that doesn't have adequate capacity. But overall, it seems that the burden on the poor, the female, and the informal economy seems to be the greatest. And it's on just multiple fronts. So I used to go to the hospital on a daily basis when I was in India. I used to take an auto rickshaw because we didn't have a place to park and all that. So I used to talk to the drivers who were from the hinterlands originally. And you essentially realize the poor can't get tested. Even in slum areas in metros, the testing is actually very inadequate. They can't afford medical care. If a patient in a family has a secondary bacterial or fungal infection, one of which was black fungus in India, one daily dose of that costs about 10,000 rupees, which is in excess of $100. This is just not something that's affordable for most people in India. They can't access doctors through informal channels to get sort of privileged treatment. And very often, if they can't get the death to be attributed to COVID, because there is some system under-reporting bias, then they can't even get the eligible support that is being provided by the state. So you get loss of earning members and the very extreme hunger. Medical expenses are one of the primary reasons for bankruptcies of households in India, besides a few others like loss of job and weddings. And you can get illiteracy and similar scarring effects as a result of all this, because you may have to put children to work in order to earn livelihood rather than send them to schools. And of course, there's impact on women. And significantly, there is a huge impact on informal economy, because once the rich have a fall in their discretionary expenditures, there's a big loss of service jobs in this space. And there's a very nice report that's documented this. Now, one thing that's important is that just like sometimes you are in a blind spot on the health curve, sometimes in emerging markets, you are also in a blind spot on the economic statistics, because the informal economy simply doesn't get reflected into the real-time GDP numbers that well. In case of India, the GDP numbers have to be revised several times because informal economy data come with significant delays, including sometimes of a year or 2 years. And then the past GDP numbers are revised. And so it takes a while to know what has been the true impact on the informal economy. And I think in interest of time, I'll skip most of this, but I just want to make one
so
point.
We have
that,
to take the time. Time is, we shouldn't neglect
yes.
the time.
So when would you like me to wrap up? Very soon.
We'll take another 3-4 minutes.
3-4 minutes. Okay. So let me just get to some of the important lessons for the emerging markets. I think I'll just focus at a high level, Markus, in interest of time. So I think to me, the lesson, as I think all of you seem to agree with, is that you have to flatten the cases curve. And it has to be through non-pharmaceutical interventions if you don't have access to vaccines. But maybe vaccines are in the end really the only way out. So as you can see here, sub-Saharan Africa has actually delivered close to single-digit number of administered doses per 100 as of June 2021. So clearly that's one of the biggest challenges. It seems the costs are not that high, but there seem to be various bottlenecks along the lines that Markus mentioned. My sense is that perhaps this just needs global coordination actually to transfer the vaccines, assuming that they will be delivered in a good way. And I think it's good to keep in mind that even 50-60% doesn't seem to be delivering herd immunity. So New Delhi, which had 56% population with antibodies in the seroprevalence surveys in December 2020, was the worst affected metro during the second wave in India. So I think the Imperial College report was right, that strategies that rely on hoping that herd immunity will be the way out don't seem to actually be on the right track overall. Then, of course, you have to build resilience in healthcare infra capacity. And I think the non-linearity point here is super important, which is that any one of the bottlenecks, be it oxygen beds, ICU beds, oxygen supply, oximeters, doctors, can become a bottleneck in the delivery of the system. You need the entire supply chain to work because otherwise you will have beds without oxygen, doctors without drugs, and so on. So, this does require healthcare capacity. A country can just produce a dashboard for every village, every township, every metro, and benchmark it to reasonable standards to know where the gaps are and how much to fill in. One point that is important is that sometimes there's a view that can we just keep shifting resources exposed to create some contingent risk sharing across medically surplus districts with medically deficient districts. It could be oxygen supply, as Markus was mentioning. It could also be supply of drugs, medical staff, etc. The experience in India was that this is very hard to do in real time if arrangements have not been made ahead of time. There is hoarding of resources. How are you going to decide what to send where when data are not that great in the first place? And more importantly, there may just not be enough time actually to do it in a timely manner. So I'm of the view that building resilience through excess capacity is probably the only way out. Yes, there are financial constraints to that, but there's a lot of fiscal expenditures on which multipliers are very, very low. One would think that this is a public good on which the long run multipliers on an economy could be very, very large. Let's skip this. I think, let me focus on this one last point, Markus, which is the importance of data. If you looked at the Imperial College report, you had these repeated waves of lockdowns, then R0 again producing a surge, then again a lockdown and so on. All that in the model is contingent on being able to measure these things very precisely. Okay? And so if you don't have data on testing, its integrity, on fatalities that are good, there is no hope of actually responding to the wave in a timely manner. Second, I want to stress the importance of the seroprevalence surveys. And I think these are not getting as much attention in my view as they should. I think they need to be run on a war footing, almost on a monthly, if not a quarterly basis, to know how much undercounting there is in the infections. And through that, one can actually get to the.
So if you have a trade-off between the speed of a survey, the timeliness of a survey versus the precision of some data, on this trade-off, can you make some quick statement?
My sense is I think the coverage is very important because I think you need the regional variation. I think these are standard antibody tests. So I think that the precision is not so much of an issue here. I think it's the sampling that's going to be far more important. I think you want a comprehensive coverage of rural and urban, and within urban, you want urban slum versus urban non-slum, because I think that will help you understand the extent, because, you know, the contact intensity is very, very different in these three profiles.
And do you think India could have learned from the Brazilian experience? So there is a cross-country service would be useful to, you know, as an input in your models, or?
Absolutely. I think India's Delta variant should be the stress test scenario for many countries right now. I think there are some seroprevalence surveys being conducted at the city level whose results are already coming out. So in case of Mumbai, actually, a seroprevalence survey was done on children this time as well. Like in Brazil, there is already a high incidence of their variant in the children. And I think that could be important to understand for Africa and other emerging markets. Okay. I think there's another international coordination that could be important, which is that a lot of countries aren't doing much genome sequencing of the variants using their samples. I think if this is not done on a real-time basis when a country is experiencing a wave, I think it can hold the entire system back, because you don't know that a new variant is emerging, and you know that everyone has to be prepared to deal with it. So I think my sense is monetary and fiscal policy needs to focus on those most affected, the poor, the women, the informal economy, and the workers. I think there's too much wealth creation, at least from a common sense perspective, in my view, for the formal economy and the large corporates relative to what may be happening to those most affected by lack of adequate medical care. And the last point, a bigger point in the spirit of more data and more accurate data, is that a lot of emerging markets are very informal. more than 50% of jobs, some cases even 70% of jobs in countries like Peru are entirely in the informal economy. And that makes it very hard to do real-time economic or medical policy making because the data come with just too much of a delay. The data are not available anywhere. The reporting systems are not organized. And I wonder if the pandemic is an opportunity for these economies to increase the formalization of their large informal economies. Maybe universal basic income could be structured. That requires a distribution process. And maybe that could be a way of getting incentives to formalize. In India, there has been a unique identification and its seamless authentication that was implemented over the last 10 years.
So was it helpful to handle the crisis in any way?
Certainly if there were to be, in India, the cash transfers have not been very large, direct cash transfers, but if there were to be cash transfers, because the unique identification helps with setting up of bank accounts, it would clearly help very significantly with that. Of course, if there were digital bank wallets, the payments could also be made much faster. And then more broadly, should there be public credit registry so that the informal economy sees value to formalizing, because that will bring them access to more competitive credit origination. And lastly, on the health front, we need to improve the registration of births, deaths, children's vaccinations, who's in schools, who's not, who's learning what. And I think this could be a massive opportunity to put all this together. Okay, so I think in interest of time, why don't I stop there, Markus?
Thanks a lot,
want me to take
It's
any
fantastic
final questions?
Big picture coming from focusing very much on health in the beginning and then moving to other economic issues at the end. So we have this tradition in this webinar series that we end at a positive note. So if you can just tell us one positive outlook, I guess you alluded to it already a little bit at the end, saying, this might be an opportunity to transform the informal sector in a more formal sector. Or is there any other positive outlook you can see or measure you can see for India or for the other emerging economies and the globe?
Yes, Markus. I think I see three actually. I think the first one is that we are already seeing, even in advanced economies, that COVID has been an accelerator for digitization, working from home. And, there will be some productivity gains associated with this, I think, and they may not be felt as immediately at the bottom of the pyramid, but I think they will trickle down. Think about the extent of commute a person has to do in the city of Mumbai if they have to get to their place every day. The average person loses tremendous amount of productivity because of the sheer exhaustion that comes from that commute. So I think digitization and e-commerce, etc., have, I think, tremendous opportunity to enhance productivity, especially in these emerging economies where transport bottlenecks are actually very, very large. Second, I would say, I think this is a wake-up call on adequacy of health infrastructure. And I see it as a positive news. I think we have all been saying for a while that medical care needs to be adequate. We need to have access to insurance. That $130 antifungal injection that I was talking about, if you had insurance, you could afford it and you could spread the cost across the system. But if you don't have insurance, there is no way that a poor person can actually afford that. So I would say, I think there is a growing recognition that we need to put in place a more robust, resilient health infrastructure and universal healthcare to the extent we can. And third, and the last one I would say is that what gives me the most hope is the evidence on vaccines. Even in the UK, where lockdowns have been extended because of the incidence of Delta variant, the spread of the Delta variant, and especially the hospitalization of cases, is really amongst the unvaccinated. The spread of the Delta variant in the United States is focused in the states where the levels of vaccination are not very, very high. So I think if the advanced economies that have reached close to herd immunity of 70, 80% on their vaccinations can work with the emerging markets and the poor countries to remove these vaccination bottlenecks for them, I think that may be the surest way to end the pandemic globally, so that new variants don't keep emerging every quarter or two.
Let's leave it at this positive note, given that there's all so much negative aspects too. But let's hope this will be a transformational period and fix the system for many, many decades to come. Thanks again, Viral. It was fantastic to have you on and get the perspective what's going on in India and how important it is to take this this undercounting into account, and how to fix it and how to get a handle on that in order to give us get us more data in order to do some policy measures subsequently.
Thank you, Markus. I'm sorry I couldn't take all the questions, but I encourage the audience to just email me separately, and I promise to report to you later today. Thank you.
Let's do that. Bye-bye.
Bye.